The following podcast is part of a certified educational activity titled Adapting Our Strategies for Decision-Making in Testing and Treatment of RET-Altered Lung and Thyroid Cancers, a Personalized Learning Journey. Access the entire activity and complete the post-test at peerview.com/ANR860. Downloadable slides and practice aids are also available.
Hello, and welcome to this activity titled Adapting Our Strategies for Decision-Making in Testing and Treatment of RET-Altered Lung and Thyroid Cancers, a Personalized Learning Journey. I am Lori Worth. I'm an Associate Professor of Medicine at Harvard Medical School, and I'm the Medical Director of the Center for Head and Neck Cancers at Massachusetts General Hospital in Boston. And Ben, would you like to introduce yourself?
Thanks, Laurie. My name is Ben Solomon. I'm a medical oncologist and the head of the Lung Medical Oncology Service at Peter MacCallum Cancer Centre in Melbourne, Australia. So our learning goals for today are as follows. Firstly, to improve your ability to implement biomarker testing for detection of RET alterations in lung and thyroid cancer based on the latest recommendations. Secondly, to augment your awareness and understanding of the evidence supporting the use of RET inhibitors in RET-altered lung cancer and thyroid cancer. Thirdly, to enhance your skills in integrating biomarker-guided targeted therapy using RET inhibitors and incorporating these into the treatment plans of patients with RET-altered lung or thyroid cancers. And finally, to offer guidance on how to better collaborate with your colleagues as well as educating and engage patients with RET-altered lung and thyroid cancer.
If you haven't already watched the introduction, which contains helpful information about this question-based, customizable, adaptive learning activity, please do so now.
So in this first module, we'll talk about why RET alterations are important and how to test for them to guide treatment decisions for patients.
So RET codes for receptor tyrosine kinase. It's expressed normally in a wide spectrum of tissues. When it heterodimerizes with the ligand co-receptor complex, RET is autophosphorylated and activated, leads to signaling through various pathways, including the RAS-RAF-MAP kinase pathway. RET plays a key role in organ development and tissue homeostasis. RET can be aberrantly activated by mutations and chromosomal rearrangements or fusions, both of which have been linked to the process of oncogenesis in different tumor types.
So as we just heard from Dr. Worth, in cancer there are two main ways that RET can be activated. Firstly, by mutations. And these are most commonly seen in medullary thyroid cancer, which occur in about 60% of sporadic tumors, and also in the majority of hereditary medullary thyroid cancers. And the most common mutation we see is the M918T. RET can also be activated by fusions, and these fusions can be seen at low frequency across a broad range of tumors, but are most commonly seen in thyroid cancers, where they can occur in 10 to 20% of non-medullary thyroid cancers, and in about 1 or 2% of non-small cell lung cancers. And the most common fusion that we see in lung cancer is the KIF5B RET fusion. And in thyroid cancers, the CCDC6 and the NCOA4 fusions are most commonly observed.
So why is identifying RET alterations in patients with cancers important? It's because we have new drugs that are now available that directly inhibit the RET kinases that are activated in these subsets of cancers. The treatment landscape really has evolved. Previously, we had in our arsenal multi-kinase inhibitors that had some anti-RET activity, but other kinase activity as well, such as VEGFR inhibition. Now, however, we have two drugs, namely selpercatinib and pralsetinib, that have been studied in clinical trials, leading to approvals by healthcare authorities around the world for the treatment of RET-altered cancers.
And we see a very similar situation in lung cancer. as we'll explore in the coming modules, RET inhibitors have profound activity in lung cancer as they do in thyroid cancer. And as we know, the key to personalized medicine is ensuring that patients get the right drug the right patients get the right drug at the right time. And this is absolutely the case for RET inhibitors in lung cancer, with significant efficacy seen with RET inhibitors. But an important aspect about this is the testing to make sure that patients with RET alterations are identified. And as we'll see in the next slide, we have a long way to go with RET testing. Although guidelines in lung cancer recommend that all patients with non-squamous non-small cell lung cancer get tested with broad-range molecular testing, we know that in the real world this is not the case. In the US and in countries around the world, data suggests that fewer than 50% of patients get appropriate testing and get directed to targeted therapy. Shown on this slide are data from an ISLC survey with over 2,000 responses from 102 countries. And we see common themes across the globe in Asia, Europe, the US, and the rest of the world, where there are significant barriers to molecular testing. And these barriers include awareness of the need to test, access to testing, delays in turnaround time, quality of testing, and cost of testing. And these results and these multiple factors really are barriers that we as a community need to overcome.
I think I would just add here in terms of in the thyroid cancer space, right now, I think we're probably even farther behind. We don't even have good data available to show to examining the rate of testing for patients with advanced thyroid cancer who are in need of systemic therapy. So I would hazard a guess that if approximately 50% of lung cancer patients might not be getting tested appropriately, is probably even a greater percentage of thyroid cancer patients who aren't getting tested.
Thanks, Laurie. And that's such an important gap that we need to overcome, because appropriate molecular testing in thyroid cancer and lung cancer is critical to optimize care. Not only does it provide insights into the biology of a patient's disease and allow for prognostic information, but it's critical because it really guides therapy and directs patients to optimal therapy, which in this case is treatment with the targeted agent directed at RET. And as we'll explore shortly, the type of testing matters. There are different forms of testing we can do. We can do testing in tissue. We can also do testing in plasma, so-called liquid biopsies. And there are different methodologies, single gene versus multiplex or next-generation sequencing, and DNA-based sequencing compared to RNA-based sequencing.
So, as we've mentioned, there are two different basic mechanisms that will activate the RET kinase in oncology. One is the structural variant of a RET gene rearrangement, which can also be referred to as translocations or fusions. And then we also see generally in medullary thyroid cancer, single nucleotide variations or point mutations, though there can also sometimes be insertions and deletions that are seen in medullary thyroid cancer in RET. Now, the testing platforms may not evaluate all of the alterations optimally, and so we're going to discuss in detail some of the various methods for testing all of our patients as optimally as possible.
And talking a bit more about the different methodologies that are available, there are multiple methods for testing for both mutations and fusions. These methods include immunohistochemistry, FISH, PCR, and next-generation sequencing, which may be DNA-based or RNA-based. Now, each of these methodologies have different advantages and disadvantages. Immunohistochemistry, whilst cheap and widely available, does suffer from significant limitations and is not a recommended method to detect either fusions or mutations. FISH, on the other hand, whilst generally available, can be expensive. There can be issues related to false negativity. It's highly technically dependent on things such as tissue fixation. Where a positive FISH result is a definite indication of the presence of a fusion, but a negative result may not always be helpful. PCR is another methodology which is generally available and cheap, but it is limited to the detection of specific fusion partners, and is not, and particularly in non-small cell lung cancer, where we're keen to look for multiple different oncogenic drivers, is not generally a recommended test. On the other hand, next-generation sequencing does have many advantages in this setting. It can look for multiple different oncogenes, including RET, and can be very sensitive, particularly if RNA-based next-generation sequencing is used. We know that DNA sequencing has limitations, particularly in the detection of fusions, and this can be overcome with the use of RNA-based methodology. So the optimal method is RNA and DNA-based next-generation sequencing approach.
One brief thing that I would add is that in NGS testing, we often get additional prognostic information beyond identifying the driver alteration. Co-mutations, for example, can be very informative. For example, in thyroid cancer, TERT promoter mutations generally correspond with slightly more aggressive disease, and I know that that's seen in lung cancer as well.
Yeah, absolutely, Laurie. And just like in lung cancer, you may identify other mutations such as BRAF mutations, which are also therapeutically actionable.
Exactly. Now, liquid biopsy is really quite appealing in terms of identifying actionable driver alterations for patients with cancer. It's a simple blood draw for patients, so the convenience factor is really quite significant. However, there are limitations as well. There is a fast turnaround time in general for liquid biopsies, and it can be a faster turnaround time than NGS testing. The sensitivity can be good in some cases, but not in all cases. For example, the sensitivity is lower in tumors that don't have high cell shedding in the blood, such as with thyroid cancers. The sensitivity is also not quite so good in detecting fusions rather than point mutations. So that certainly is one of the limitations of liquid biopsies or ctDNA testing. The specificity is excellent if a driver alteration is identified. However, if a targetable driver alteration is not identified, it could be still present if tissue NGS testing is done. The cost is variable. I think it depends in part the region of the world where testing is done and whether it might be covered by insurers in the U.S., for example, by other payers in other parts of the world. And one of the limitations related to cost is if the ctDNA testing is not informative, then in some centers, tissue NGS testing will then be ordered. And so then two different molecular testing platforms are utilized with that approach, and that can really be quite expensive.
So we do have some current guidelines, both for lung cancer and thyroid cancer testing for RET provided by the NCCN. To summarize the guidelines from the lung cancer perspective, They indicate that FISH methodology can be deployed, but highlight that it may underdetect some fusions. Targeted real-time PCR assays can be used, but they're also unlikely to detect fusions with novel partners. And really, next-generation sequencing-based methodology is the recommended approach, as it has a high specificity, and an RNA-based NGS is preferable to a DNA-based NGS for fusion detection.
Now, the NCCN guidelines are somewhat different for thyroid cancers. Molecular diagnostics are indicated for patients with advanced thyroid cancer who are in need of systemic therapy, because, of course, many patients with thyroid cancer will simply have tumor localized to the thyroid gland, have surgery, plus or minus radioactive iodine, and never need any other systemic therapy. So that's very different than the lung cancer setting. But for patients with advanced follicular-derived thyroid cancers, such as papillary thyroid cancer, follicular thyroid cancer, or even anaplastic thyroid cancer, when a systemic therapy is anticipated as being necessary in that patient's journey, molecular testing is recommended for treatment decision-making. And this testing should include testing for RET gene fusions in these cancers. Now, for patients with medullary thyroid cancer, for whom systemic therapy is anticipated, identifying RET mutations is critically important. In medullary thyroid cancer, RET gene testing is somewhat complicated because patients with medullary thyroid carcinoma may have hereditary disease, and all patients who are diagnosed with medullary thyroid cancer should have germline RET gene testing in order to determine whether or not they have hereditary disease, either MEN2A or MEN2B, which not only affects that patient's treatment, but also can affect the patient's first-degree family members. If patients are germline RET negative, however, and need systemic therapy, then they should undergo somatic testing of the tumor in order to detect somatic RET mutations that may be present in RET germline wild-type patients with medullary thyroid cancer.
And we also have an algorithm for testing that ESMO has proposed. And the algorithm in the context of lung cancer recommends initially testing with that's tissue-based with next-generation sequencing. Now, if tissue is not available, a liquid biopsy is also indicated as an appropriate method for testing. Now, if RET fusions are detected on either assay, the recommendation is to progress to treatment with a RET inhibitor. If it's not detected, then treatment with standard therapy. If next-generation sequencing is not available, then FISH or RT-PCR may be used. Now, the guidelines also do extend to thyroid cancer, Laurie.
Yeah, so for the ESMO guidelines for the follicular-derived thyroid cancers, this same algorithm applies, where NGS testing of the tissue sample is recommended with the same approach to identifying tumors that harbor RET alterations or RET fusions, in whom a RET-specific therapy would be indicated. And again, I would highlight the fact that liquid biopsies really are not as sensitive for patients with thyroid cancer in general for detecting the presence of RET fusions or even RET mutations. So while it's incorporated in the ESMO guidelines, I'm not sure really if liquid biopsies in thyroid cancer patients are ready for prime time. One other thing that I would say that's a little bit unique to thyroid cancer is that many patients can be diagnosed and undergo their initial treatment for thyroid cancer a number of years prior to the development of progressive metastatic disease when other systemic therapy is necessary. And because these are driver alterations, the tissue from the patient's original surgery can often be used if it's not too old for NGS testing. So we don't necessarily have to do a new biopsy at the time of prior to initiating systemic therapy in patients with thyroid cancer if the original cancer specimen is available for testing. There may be other clinical reasons, however, to do a biopsy. Now, with medullary thyroid cancer, there are specific ESMO recommendations and an algorithm for identifying patients who harbor RET mutations. The guidelines start with germline RET testing for every patient who has been diagnosed with medullary thyroid cancer. If a patient is found to be RET germline positive, they should indeed undergo genetic counseling because of the implications for their own health and harboring other tumors that are associated with MEN2A and MEN2B, but also because of their first-degree family members who really should be notified of the potential for harboring a germline RET mutation themselves. In those patients that are germline RET negative, when patients with medullary thyroid cancer do need to have systemic therapy, tissue testing with NGS testing is recommended.
Yeah, so bringing together, I guess, the various different guidelines, I think we can see that next generation sequencing is the recommended method that enables accurate and tissue-efficient testing for RET alterations and also other biomarkers, both in lung cancer and thyroid cancer. And this methodology allows detection of both RET point mutations as well as fusions. And I think, as we heard, and I think Laurie made the point very nicely, in thyroid cancer, molecular testing molecular testing of tissue is the preferred method for detecting RET fusions or mutations. We have similar issues in lung cancer in patients with intrathoracic disease, that there can be sometimes a low frequency of detectable ctDNA in plasma, as is the case in thyroid cancer. And it's important to wait where we can for biomarker testing before making treatment recommendations, because the results of the testing really do impact what treatment a patient receives in both situations, right, Laurie?
Yeah, and I think that my key takeaway really is that because we have now such good RET-specific treatment options for patients with RET-driven cancers, we basically do not want to miss a RET alteration in a single patient. Whenever possible, we really want to identify every single patient that has RET-driven disease because we now have highly effective and very well-tolerated RET-targeted therapies.
In this next module, we'll talk about the latest evidence on RET inhibitor therapy in lung cancer and how to best integrate these therapies into practice. So initial attempts to target RET involved non-selective inhibitors of RET, such as vandetanib, lenvatinib, and cabozantinib. And these drugs tended to suffer from modest efficacy, certainly in comparison to other targeted agents such as EGFR inhibitors, ALK inhibitors, and ROS1 inhibitors, but also from significant toxicity. However, recently we've had development of selective, highly potent inhibitors that inhibit RET with relatively little activity against other kinases. Two of these inhibitors, selpercatinib, which is also known as LOXO-292, and pralsetinib, which is also known as BLU-667, have progressed through clinical trials. And we'll discuss some of the clinical trial data with these compounds, beginning with selpercatinib. So selpercatinib was assessed in a large phase 1 trial called Libretto 001. And there was a large cohort of patients with non-small cell lung cancer that entered into this study. And we now have data from from the non-small cell lung cancer cohorts, both in patients who had received prior treatment with platinum-based chemotherapy, which is standard therapy, and also in patients who are treatment naive. And we see significant efficacy in patients who had received prior platinum therapy, as you can see from the waterfall plot on the left. The majority of patients have some reduction in tumor size, and 61% of these patients had reductions in size that met criteria for partial response, partial or complete responses. And with median, and these responses do seem to be durable. With a median follow-up of 15 months, 58% of responses were ongoing in this cohort. In the treatment-naive cohort, the objective response rate was 84%, and the majority of responses were ongoing at the time of with follow-up. What we've also seen is that selpercatinib is active in the brain. In patients with measurable CNS disease, even in patients who had received multiple lines of prior treatment, not just with chemotherapy, but with other non-selective RET inhibitors, there was reduction in tumor size with a CNS objective response rate of 82% seen in the Libretto 001 study, including 23% of patients with complete intracranial responses. These data have been recently updated, and with additional patients and additional follow-up, the results do remain robust, with an objective response rate of 84% in treatment-naive patients and 61% in patients who had received prior treatment. These responses do seem to be durable, with a median progression-free survival of 22 months in treatment-naive patients and 24.9 months in previously treated patients. And I think what's also really interesting is it does appear that these drugs do seem to alter the natural history of disease, with really unprecedented survivals being seen in this population, with 3-year overall survival rates of 57% in the treatment-naive cohort and similar rates in the platinum pre-treated cohort. Again, the CNS data seems robust, with an 84% objective intracranial response and a 26% complete intracranial response. And treatment of brain metastases is really important in patients with lung cancer, as many patients with lung cancer present with brain metastases, but also develop brain metastases over the course of their treatment. And brain metastases have a significant impact on not just on morbidity and mortality, but also a functional impact on patients' quality of life. Now, in terms of toxicity, overall, selpercatinib did seem to be tolerated well. Only 9.6% of patients needed to discontinue treatment related to adverse events. So what sort of adverse events do we see? So we see some common adverse events such as a dry mouth and edema. We also see some gastrointestinal adverse events such as diarrhea or abdominal pain. And other adverse events of note include hypertension and alterations in liver function tests. Now, given the data from the phase 1 study showing efficacy in patients receiving selpercatinib in the first-line study, a phase 3 study called Libretto 431 was initiated to test selpercatinib compared to standard of care treatment in the first-line setting in non-small cell lung cancer. And these results were reported at the ESMO 2023 meeting. So the rationale for the study was the strong strong data in treatment-naive patients in the Libretto 001 study. And the standard of care treatment for these patients had previously been chemotherapy with pembrolizumab. Now, so the Libretto 431 study was designed to test the efficacy of selpercatinib in the first-line setting. So patients in this, so it compared treatment with selpercatinib to standard of care treatment with chemotherapy with or without pembrolizumab. The design of the study is shown here. Patients with newly diagnosed non-squamous non-small cell lung cancer with a RET fusion identified via next-generation sequencing or PCR were randomized in a 2-to-1 ratio to treatment with selpercatinib, given at a dose of 160 milligrams twice daily, or to treatment with to chemotherapy plus pemetrexed, with or without pembrolizumab. The stratification factors were based on geography, brain metastases, and whether an investigator chose to give pembrolizumab or not. There was crossover in patients on the chemotherapy arm who progressed, who had centrally confirmed progression, and these patients were allowed to receive selpercatinib on progression. The primary endpoint of the study was progression-free survival by blinded independent central review, firstly in the intent to treat pembrolizumab population, and also the entire study population. And key secondary endpoints included objective response rate and CNS activity, safety, and patient-reported outcomes. So these are the primary results of the study, and the study was positive for its primary endpoint of progression-free survival. So in the population of patients receiving pembrolizumab as part of their control arm, the hazard ratio was 0.46. The median progression-free survival with selpercatinib was 24.8 months compared to 11.2 months. So a really impressive result. And of note, the control arm, the chemotherapy pembrolizumab arm, did probably even a little bit better than we would expect by historical standards. And in the entire study population, the intent to treat population, very similar results were seen: a hazard ratio of 0.48, a median progression-free survival of 24.8 months with selpercatinib, compared to 11.2 months with chemotherapy with or without pembrolizumab. Now, when we look at the forest plot, we can see that benefit was seen pretty much across all the pre-specified subgroups. Benefit was seen regardless of ethnicity, and in both patients with and without brain metastases. There didn't seem to be a differential effect based on the type of RET fusion partner that was detected either. Now, in terms of objective response rate, so the overall response rate by RECIST criteria was higher in the selpercatinib arm, with an 83.7% objective response rate with selpercatinib compared to 65.1% with the chemotherapy pembrolizumab arm. And these responses were durable, with a median duration of response of 24 months with selpercatinib compared to 11 months in the control arm. And the intracranial activity was consistent with what we saw in the phase 1 study, an 82% intracranial objective response rate with selpercatinib compared to 58.3% intracranial response in the chemotherapy pembrolizumab arm. I will mention that this is a relatively small number of patients with measurable disease, but the results were consistent with what had previously been seen, speaking to the intracranial activity of selpercatinib. Another important outcome from the study was the effect of selpercatinib on CNS progression. As I mentioned previously, in non-small cell lung cancer patients, that there is a progressive development of brain metastases over time. And in the study, there were mandated CNS imaging. And from this, we were able to learn that selpercatinib reduced the rate of CNS progression with a hazard ratio of 0.28 compared to chemotherapy and pembrolizumab, which is a really meaningful endpoint for patients. In terms of toxicities, the most frequently observed toxicities were elevations of the transaminases, AST and ALT, also hypertension, diarrhea, edema, and dry mouth, again consistent with what was seen in the phase 1 study. The toxicities from chemotherapy are what we expect in terms of myelosuppression being the main, and gastrointestinal toxicities being the main toxicities. In terms of patient-reported outcomes, selpercatinib resulted in an improvement in the time to in patient-reported pulmonary symptoms and physical function, and delayed the time to deterioration of these measures. So I think the Libretto 431 study was an important study which really firmly establishes selpercatinib as the optimal first-line therapy for a newly diagnosed patient with RET-rearranged lung cancer. And these results really do reinforce the importance of upfront and early genomic testing to identify RET fusions at the time of diagnosis to guide and inform optimal first-line therapy, which, if you identify a RET fusion, is treatment with the selective RET inhibitor. And for more information, the results from the study were published simultaneously with the ESMO presentation in the New England Journal of Medicine. So we also have quite similar data from another selective RET inhibitor, pralsetinib, which, like selpercatinib, is highly potent against RET with relatively little activity against other kinases. This compound was evaluated in a phase 1/2 study called the ARROW study, and very similar to the results with selpercatinib, in the non-small cell lung cancer cohort, patients both who had received prior platinum-based chemotherapy and patients who were treatment naive were evaluated. In the patients who had received prior platinum-based chemotherapy, the objective response rate was 62%. In patients who had received, in patients who were newly diagnosed and treatment naive, the objective response rate was a bit higher at 79%. Toxicities with this compound have some overlap with selpercatinib, with some slight differences as well. So again, elevations of transaminases were seen, as well as hypertension. But in addition to that, there were some hematological findings with neutropenia and anemia also being frequently observed. One other important aspect of both studies was that both phase 1 studies included cohorts of patients who had RET fusions identified in different histologies. These are results now shown with the selpercatinib study in patients with a range of tumor histologies, but all of which had RET fusions. And as you can see from the waterfall plot, responses were seen regardless of tumor histology, indicating that really it is the presence of the RET fusion that drives the biology. And regardless of the histology, if you're able to identify a RET fusion, treatment with a RET inhibitor is likely to result in best outcomes. And on the basis of these results, in September of 2022, the FDA approved selpercatinib for patients with RET gene fusions that had progressed on prior systemic treatment, regardless of histology, a so-called tissue-agnostic approval. We also have very similar data with pralsetinib, with responses seen across a range of different histologies. this waterfall, and that's shown nicely in this waterfall plot where different histologies are shown with different colored bars. And we see that, again, it's not the tumor type, but the presence of the fusion that drives the efficacy of these agents and therefore benefit to patients. So in summary, RET gene rearrangements or RET fusions are found in 1 to 2% of non-small cell lung cancers. Testing, ideally with next-generation sequencing, is required to identify these fusions. Selective RET inhibitors such as selpercatinib and pralsetinib are highly active and have activity in the brain. And we see the best results when used early, and we have results from the first phase 3 study with a RET inhibitor in the first-line setting, the Libretto 431 study, which really does establish upfront treatment with selpercatinib as the optimal first-line therapy for a patient with newly diagnosed RET rearranged lung cancer. So in terms of illustrating practical considerations related to treatment with RET inhibitors, I think it's useful to look at a case presentation of a patient with a RET rearranged lung cancer. This is a case of a young man we saw in our practice who is a 37-year-old man who had had a light smoking history, who presented with rapidly progressing disease in his lung, but also with brain metastases as well as soft tissue metastases. He had standard of care molecular testing, which involved EGFR testing, KRAS, BRAF, MET testing, as well as ALK and ROS1 FISH testing. And his PD-L1 was 40%. So this was the standard panel that we were using at that time, which, as you know, did not include RET FISH or next generation sequencing. We did request next generation sequencing, but did not have results available in time to start therapy. So because of the clinical urgency of the situation, he commenced therapy with carboplatin and pemetrexed chemotherapy together with pembrolizumab. Unfortunately, he had very rapid progression after 2 cycles of therapy. Fortunately, next generation sequencing using a DNA and RNA based panel was performed, including a platform called TSO 500. This is a multi-gene platform which tests over 500 different genes, but also has an RNA component which provides a very sensitive mechanism to look for fusions, including RET. So when we got the result back, we were pleased that we were able to identify a KIF5B RET fusion that was identified. So on the basis of this result and the finding of the KIF5B through next-generation sequencing, the patient was able to commence treatment with a selective RET inhibitor, selpercatinib, and had a dramatic response, both radiologically, as you can see, with a dramatic reduction in size of his lung mass, but more importantly, a dramatic and durable clinical response to therapy.
In the next module, we will talk about the latest evidence on RET inhibitor therapy in thyroid cancer and how to best integrate these therapies into practice. All right, let's focus on the evidence. So we do now have the first-generation RET-specific inhibitors that have been studied in clinical trials and are now available in clinic. Prior to the development of the highly selective RET inhibitors, we did have multi-kinase inhibitors that did have anti-RET activity, particularly cabozantinib, vandetanib, and lenvatinib, that inhibited the RET kinase, but other kinases as well, including VEGFR2, where we think that some of the toxicity from these older TKIs was derived. And now we do have two highly potent and specific RET inhibitors, namely selpercatinib, previously referred to as LOXO-292, and pralsetinib, previously referred to as BLU-667. So let's go over the initial selpercatinib phase 1-2 data in patients with RET-activated thyroid cancers, as was demonstrated in Libretto 001. There were a couple of thyroid cancer patient populations that were enrolled. We enrolled patients with RET fusion-positive follicular-derived thyroid cancer, namely differentiated thyroid cancer, but there were a couple of patients enrolled also who had RET fusion-positive anaplastic thyroid cancer. We now have updated data on 65 patients with RET fusion-positive thyroid cancer from the Libretto 001 trial. We took a look at patients with RET fusion-positive thyroid cancer who were treatment naive, and then patients that had received a prior TKI therapy. And in the treatment-naive patient population with RET fusion-positive thyroid cancer, we saw an objective response rate by the blinded independent committee review of almost 96%. And for the patients that had received prior TKI therapy, the objective response rate was 85%. These responses are really quite durable. The median progression-free survival had not yet been reached at the time of data cutoff in the patients that were treatment naive, and it was 27 months in the patients that had received a prior therapy. We also saw long durations of response in this patient population as well. In terms of the safety in patients with RET fusion-positive thyroid cancer, the safety profile was very similar to the overall safety profile for all patients in Libretto 001. There were 2 patients in this group of patients who discontinued treatment due to treatment emergent adverse events for a discontinuation rate of only 3%. Most of the adverse events that were seen were grades 1 or grade 2 that were treatment-related. And the most common treatment-related adverse events included diarrhea, dry mouth, hypertension, fatigue, and other adverse events were seen as well. Here we see the waterfall plot for patients who were treated with selpercatinib on Libretto 001 with the RET fusion-positive thyroid cancer. The waterfall plots show that every patient who was enrolled did have some degree of tumor shrinkage, and the majority of patients did have objective responses. And you can see in the Kaplan-Meier curve that the progression-free survival is really quite long, and the median progression-free survival has not yet been met. In the patients with RET fusion-positive thyroid cancer who had been previously treated, we again see in the waterfall plot very high objective response rates, with most patients achieving at least a partial response. I'll also point out that we see a pretty high rate of complete responses in these patients, as you can see in the waterfall plot, with those bars going all the way down to 0 to the right of that waterfall plot. And in the patients with previously treated RET fusion-positive thyroid cancer, the median progression-free survival is quite durable and was defined by the Kaplan-Meier curves at 27 months. Now, Libretto 001 also enrolled a large cohort of RET-mutated medullary thyroid cancer patients. Overall, in the updated presentation, we've reported now on 324 patients with RET-mutant medullary thyroid cancer. Let me show you those data. In terms of the patients with RET-mutated medullary thyroid cancer, we took a look at 3 different patient cohorts. We looked at patients who were entirely treatment naive and had not received any prior TKI therapy. There were 116 treatment naive RET-mutated medullary thyroid cancer patients. We also took a look at patients that had not received any prior vandatinib or cabozantinib, both of which are approved for medullary thyroid cancer. there were 143 cabozantinib and vandetanib naive patients with medullary thyroid cancer enrolled in Libretto 001. And then there was a cohort of patients with medullary thyroid cancer who had received either previous cabozantinib, vandetanib, or both, and there were 152 of those patients. In terms of the treatment-naive patients with medullary thyroid cancer, the objective response rate by independent review was close to 85%. In those patients that were cabozantinib and vandetanib naive, the objective response rate was close to 83%. And in those patients that had received prior cabozantinib and or vandetanib, the objective response rate was still quite high at almost 78%. Again, we're seeing very durable responses in the patients with medullary thyroid cancer in Libretto 001. The median progression-free survival in the treatment-naive patients has not yet been reached after quite a long period of follow-up at this point in time. In those patients who were cabozantinib and vandetanib naive, also median progression-free survival has not yet been met. And then in the patients that had received prior cabozantinib and or vandetanib, still we see quite durable responses with a median progression-free survival in that patient population of 41 months. Now, in Libretto 001, the safety in the patients with RET-mutated medullary thyroid cancer was very similar to the overall safety population for the entire trial. There were 9% of patients who discontinued treatment due to treatment-emergent adverse events, and 5% of these were considered treatment-related. The most common grade 3 or higher adverse events that were experienced included diarrhea, hypertension, fatigue, and transaminitis. I will mention, for the sake of being complete and for safety's sake, we do see uncommonly QTc prolongation, so it is important to follow EKGs in patients prior to and after initiating selpercatinib therapy. Now, in Libretto 001, for patients with the treatment-naive RET-mutated medullary thyroid cancer, I just want to show here the really beautiful waterfall plots showing the best overall response rates. Most patients are achieving a response, and we're seeing high rates of complete responses as well as the waterfall plots do demonstrate. And the median progression-free survival has not yet been reached in this patient population, as the Kaplan-Meier curve shows. And here we see the waterfall plots for patients who were cabozantinib and vandetanib naive with RET-mutated medullary thyroid cancer, and very similar to the waterfall plot for the patients that were entirely treatment naive. And again, long progression-free survival with a median not yet being reached. And here we see the waterfall plots for the patients who had received prior cabozantinib and or vandetanib with RET-mutated medullary thyroid cancer in Libretto 001, with a majority of patients achieving at least a partial response. But even in this previously treated patient population, we're seeing a pretty high rate of complete responses. Now, let me share with you the data recently presented at ESMO in 2023, investigating selpercatinib compared to cabozantinib or vandetanib in a phase 3 trial in RET-mutated treatment-naive medullary thyroid cancer patients. And this data was presented by Julien Hadou. The background for the trial, of course, was the beautiful data that was seen in Libretto 001 with selpercatinib, whereas with the previously established standards of care, namely cabozantinib and vandetanib, the EXAM and ZETA trials, respectively, showed that both of these drugs, compared to placebo, do improve progression-free survival for patients with advanced medullary thyroid cancer, and both were approved as first-line treatment for these patients. The limitations of these drugs, however, probably are derived from suboptimal RET inhibition and from toxicity of the multikinase inhibitors with long pharmacologic half-lives that can complicate the management of patients on these therapies. And whereas with selpercatinib, In Libretto-001, the phase 1/2 trial, we found that selpercatinib, of course designed as the highly potent and specific RET inhibitor, there we saw really compelling activity in patients with RET-mutated medullary thyroid cancer in terms of high response rates, long progression-free survival, and very good tolerability. So Libretto 531 was designed to compare the selpercatinib in the first line for patients with RET-mutated medullary thyroid cancer to cabozantinib or vandetanib per physician's choice in order to establish the optimal first-line regimen for these patients. Here we see the schema for Libretto 531, in which patients with locally advanced, unresectable, and or metastatic RET-mutated medullary thyroid cancer who were treatment naive and had disease progression within 14 months of study entry and harbored a RET mutation, either identified by NGS or PCR, were enrolled and randomized in a 2-to-1 fashion to selpercatinib versus physician's choice cabozantinib or vandetanib at their approved doses. Selpercatinib was administered at 160 milligrams BID, which is the recommended phase 2 dose established by Libretto 001. There were 193 patients randomized to selpercatinib and 98 patients randomized to physician's choice standard of care therapy. I'll note that the design did not incorporate blinding, which was approved by healthcare regulatory agencies because it was felt that it would be quite obvious to both physicians and patients which arm the patients were randomized to. When patients did have confirmed disease progression on cabozantinib or vandetanib, they were allowed crossover to selpercatinib. The primary endpoint of the trial was progression-free survival per RECIST 1.1 by blinded independent review. And the key secondary endpoints included treatment failure-free survival by blinded independent review, PFS, objective response, overall survival, and safety. Here we see the top-line results in terms of the progression-free survival. The hazard ratio for progression-free survival indicating selpercatinib's benefit over cabozantinib or vandetanib was 0.280. So the improvement in progression-free survival is highly statistically significant. The median PFS was not yet reached with selpercatinib, whereas with the standard of care arm, the median PFS was 16.8 months. So selpercatinib demonstrated a statistically significant improvement in progression-free survival. And that progression-free survival was observed in all subgroups, as the forest plot here shows. So whether patients harbored the RET M918T mutation or not, for example, there was benefit with selpercatinib. And we also saw benefit whether the patients had been randomized to either had been randomized to the standard of care arm and had physician's choice cabozantinib or vandetanib. And here we see the Kaplan-Meier curves for treatment failure-free survival. This was assessed by blinded independent review. And let me just go over the definition because this was a novel secondary endpoint that was incorporated into the study. And TFFS was defined as the time from randomization to the first occurrence of either progressive disease or discontinuation of treatment due to treatment-related adverse events that was reviewed centrally by blinded review or death. And you can see that there was, again, a statistically significant improvement in TFFS with selpercatinib as compared to cabozantinib, and that hazard ratio is 0.254, which we might have expected thinking about the hazard ratio for PFS being 0.28. The median TFFS for selpercatinib has not yet been reached, whereas it was almost 14 months with the standard of care arm. So selpercatinib demonstrated a statistically significant improvement in treatment failure-free survival as well as progression-free survival. In terms of the objective response rates, the objective response rate with selpercatinib was 69%, whereas it was 38.8% with cabozantinib or vandetanib in the standard of care arm. In terms of complete responses, we saw 11.9% of patients achieving a complete response with selpercatinib and 4.1% of patients achieving a complete response with cabozantinib or vandetanib. And the median duration of response was not yet reached with selpercatinib, whereas it was 16.6 months in the standard of care arm. And here we see the waterfall plots for selpercatinib juxtaposed to those of cabozantinib or vandetanib, with a higher percentage of patients achieving a response with selpercatinib, as demonstrated here by these waterfall plots, including patients achieving a complete response rate with selpercatinib, and more patients than the patients that had achieved a complete response rate or a complete response with cabozantinib or vandetanib. Now, the overall survival was presented at ESMO as well, and there was a separation of the curves, although I'll note that this is really the survival events were in a small number of patients, and more follow-up is really needed for us to know if there is indeed an overall survival benefit with selpercatinib from the Libretto 531 trial. The safety of selpercatinib compared to cabozantinib or vandetanib is shown here. I think you can appreciate in that tornado plot that the frequency of adverse events seems less with selpercatinib compared to the standard of care therapy, as well as the grade of adverse events. So the light blue and gray bars show grade 1 and 2 adverse events, whereas the darker blue and gray parts of the bars show grade 3 or higher adverse events. So with selpercatinib, hypertension, dry mouth, transaminitis, and diarrhea were the most frequent adverse events noted, whereas with cabozantinib or vandetanib, the most common adverse events included diarrhea, hypertension, transaminitis, but we saw other adverse events as well, including some GI toxicity, nausea and vomiting, and then also hand-foot syndrome. For selpercatinib, there were permanent discontinuations of selpercatinib in 4.7% of patients, whereas with cabozantinib or vandetanib, the permanent discontinuation was 26.8% of patients. So to conclude, regarding Libretto 531, selpercatinib is an active and selective RET inhibitor that showed superior efficacy compared to cabozantinib or vandetanib in first-line patients with RET-mutated medullary thyroid cancer, with a significant improvement in progression-free survival, treatment failure-free survival, with hazard ratios of 0.28 and 0.254, respectively. Selpercatinib also showed a favorable safety profile compared with the multikinase inhibitors, and the adverse events that were seen attributed to selpercatinib were similar to what had been seen previously in the Libretto 001 trial. I think that these results absolutely highlight the importance of RET selectivity in patients with RET-mutated medullary thyroid cancer, and highlight the timely implementation of biomarker testing in patients with medullary thyroid cancer who are going to be needing systemic therapy. And the Libretto 531 results do support selpercatinib as the first-line standard of care for patients with advanced RET-mutated medullary thyroid cancer. The Libretto 531 trial was published in the New England Journal of Medicine simultaneously with the ESMO 2023 presentation. Now let me touch upon pralsetinib in thyroid cancer briefly. As I mentioned earlier, pralsetinib did initially garner an accelerated approval for the treatment of patients with RET-mutated progressive medullary thyroid cancer based on data from the ARROW trial, in which there were several thyroid cancer cohorts enrolled, including RET-mutated medullary thyroid cancer, as well as RET fusion-positive thyroid cancer. The application for accelerated approval was, however, withdrawn for medullary thyroid cancer when a confirmatory phase 3 trial was not performed. So I just want to highlight the pralsetinib data in RET fusion-positive thyroid cancer, which has retained an accelerated approval for this patient population in the United States. Now, in patients with RET fusion-positive thyroid cancer enrolled in the ARROW trial treated with pralsetinib, the objective response rate was 90.9%. And in those patients with RET fusion-positive thyroid cancer, the median progression-free survival was 25.4 months. The safety of pralsetinib in the thyroid cancer population was similar to the safety profile of pralsetinib in the overall ARROW trial population. PROs were also studied and remained improved or stable in the patients with thyroid cancer that were enrolled in the ARROW trial and treated with pralsetinib. All right, let's talk about practical considerations for real-world practice with RET inhibitor therapy in patients with thyroid cancer. And I want to share a case with you of a patient of mine with sporadic medullary thyroid cancer diagnosed in 2014. He was 47 years old at the time. His diagnosis was identified preoperatively, and his calcitonin and CEA tumor markers were evaluated preoperatively. They were quite high, 32,000 and 1,200 respectively, suggesting that this patient was at a high risk for harboring distant metastases. Nonetheless, he appropriately underwent a total thyroidectomy and was found to have a medullary thyroid cancer that was relatively small with extrathyroidal extension. However, 11 of 11 cervical nodes were positive, the largest of which was 2.5 centimeters in size. He shortly thereafter underwent a revision neck surgery, and further nodal disease was resected, including very bulky disease with a 4.2 centimeter posterior right cervical node that showed extranodal extension, and other nodes were positive as well. The patient was appropriately tested for germline RET mutation and was found to be wild type and therefore did not harbor MEN2A or MEN2B. 2 years later, he had rising tumor markers. His calcitonin levels had gone up to 26,000, and CEA, which had gone down after surgery, was back up to 115. A PET CT was done showing very extensive bulky disease in the bilateral neck and mediastinum. He was started at that time on cabozantinib at the FDA-approved dose of 140 milligrams daily. We also did tumor NGS testing at the time, and this tumor was found to harbor a somatic RET deletion, as you can see notated here in this slide. He had a beautiful response initially to cabozantinib. His restaging imaging showed a decrease in the bulky disease that was present in the neck, as well as in the bulky mediastinal disease. The cabozantinib had to be held briefly when the patient was diagnosed with immune thrombocytopenia. And then, unfortunately, the patient was lost to follow-up. He did stop cabozantinib in October of 2018 due to losing his healthcare insurance. However, he represented to our clinic in February of 2019 because of an increasing large right neck mass. His tumor markers had gone up again with a calcitonin level of more than 25,000 and CEA of 656. And CT imaging showed massive disease progression in the neck and in the mediastinum. He was enrolled as soon as we could on Libretto 531 and started selpercatinib at the recommended FDA-approved dose of 160 milligrams BID in the beginning of, or in the middle of February of 2019. On selpercatinib, the patient reported to us that his neck mass seemed noticeably smaller, even by day 8 of treatment. He had diarrhea that was grade 1 at baseline, and the diarrhea very quickly resolved. Patients with medullary thyroid cancer who have high calcitonin levels have calcitonin-mediated diarrhea. So when the calcitonin levels go down, we often see significant improvement in diarrhea, which I think makes a big difference for these patients' quality of life. He developed a grade 1 rash on selpercatinib that was treated symptomatically. He had grade 1 fatigue at presentation, and that resolved. His appetite normalized, and he actually started gaining weight after starting selpercatinib. You can see here his graphing of his tumor markers. The calcitonin and CEA levels dropped quite briskly, particularly the calcitonin level dropped to within the normal range very shortly after initiating therapy. And you can see here in the CT scans that, again, there was a dramatic decrease in the bulky disease in the patient's neck as well as in the mediastinum. I show here the RESIST response that was taken after he had been on study for approximately 14 months as a snapshot of his response. And at that point, he had almost a 70% decrease in the sum of his longest diameters based on RESIST version 1.1. This patient remained on selpercatinib. However, he did unfortunately experience disease progression after 36 months of treatment. He developed oligoprogression in the left mediastinum only, as you can see here in that node highlighted on the CT scan. We did do an endobronchial biopsy of this lesion. It was confirmed to be medullary thyroid cancer, and we did NGS testing looking for the mechanism of acquired resistance, and we identified an acquired KRAS G13A mutation. That, of course, was not actionable. The patient remained on study. We held selpercatinib. He received radiation therapy to the mediastinum, and then he resumed selpercatinib. And I can happily report that he remains on the Libretto-001 study to date. He, apart from that one side of oligoprogressive disease, he remains in response elsewhere. And at the time of his last follow-up, in terms of his imaging in March of 2023, he remains in response radiographically, except for the one side of disease progression. And you can see his calcitonin and CEA tumor markers remain quite low on selpercatinib. In the final module, we will talk about the importance of multidisciplinary collaboration as well as patient education and engagement in care decisions to improve biomarker testing and treatment outcomes in RET-altered cancers.
Yeah, so I think we really are in the era of precision medicine for both lung cancer and thyroid cancer, and precision medicine is about getting the right drug to the right patient at the right time. And in the context of lung cancer with harboring RET rearrangements, it's really about making sure patients get identified, get their tumors tested, and if the tumors are found to have RET gene rearrangements, making sure that they get a RET inhibitor as early as possible. And what we know is that a multidisciplinary approach is critical to doing this, and which is not reliant on just one practitioner, the medical oncologist, but really the entire team that is involved with the patient right from the time of their diagnosis. So the critical first step is making sure that there's enough tissue. And this involves making sure that we do biopsies, that not just cytology is collected, but adequate tissue to perform molecular testing, not just for one gene or sequential testing of multiple genes, but really we need to think about getting adequate tissue to allow testing for all the potentially actionable targets, which in the context of lung cancer, may be up to 10 different oncogene targets at the moment. So adequate tissue is important. There are situations where we even have to consider rebiopsy if there isn't sufficient tissue on the initial testing. Then I think it's important also and this involves working closely with our interventional radiologists, our pulmonologists, our surgeons, but also it's important to work closely with the pathology department and molecular pathologists to ensure adequate processing of tissue, to allow efficient interrogation of that tissue, and to make sure that molecular testing is prioritized. Then I think it's also important to be aware of the importance of testing in dictating first-line treatment, and really work towards minimizing turnaround times from when the test is requested to when it's done. So part of that involves ordering the test early, ideally through reflex testing done by a pathologist, and really working very hard to make sure that we have results prior to initiation of first-line therapy. In other situations, it may be important, if we don't have enough tissue, to consider things such as a liquid biopsy. And in patients who have recurrence from prior surgery, as Dr. Worth, I'm sure, will discuss in the context of thyroid cancer, testing archival tissue may be helpful for doing this. But I think really what this speaks to is the importance of a coordinated, multidisciplinary approach, making sure that testing happens, that it happens early, and that it informs initial therapy. And Dr. Worth, I think it's a very similar situation in thyroid cancer.
It is. And, I think what's really key here is communication. There's not one specific algorithm that will work in every institution around the country and around the world, but communicating with the key players in order so that your surgeon or your interventional pulmonologist knows that you need tissue for molecular testing, and then knowing what the best assay is for that particular disease setting that's available in your particular institution is also key. So asking the right questions of the right people is really, I think, critical. And, I would add to the right drug for the right patient at the right time. We can maybe start out by saying the right test for the right patient to identify the right drug at the right time. The testing is getting the testing done well, really is the key to identifying every single patient. Now, with thyroid cancer, many patients do have a relatively indolent natural history of disease where they may have had original thyroid cancer surgery done a number of years earlier. That tissue can often be used for testing because we're looking for driver alterations that are present in the original cancer as well as in the progressive metastatic disease. And these days, we're often able to extract good DNA and RNA from those archival specimens for NGS testing.
Yeah, and I might just sort of add to your point. One other thing you sort of talked about the difference in natural history, that patients may not need to have therapy straight away. In lung cancer, it's a little bit different, that patients with metastatic disease really need to start early. But we do have patients who've started therapy and even have done well on therapy but progress. And then when we look back, they've never actually been tested for RET. And it's important to remember that. And like you said, you need to do the right test. If you don't do the right test, you don't find it, and go back and make sure that we test for that situation, test for RET and other actionable oncogenes that they may not have been initially tested for.
That's a very good point. Again, in the interest in not missing a single patient who's out there who might benefit from treatment. Another thing that is unique to the thyroid cancer space is the need for medullary thyroid cancer to really be thinking about two different types of tests. do need to rule out germline RET mutations in any patient who is diagnosed with medullary thyroid cancer. But in patients who are either RET wild type from a germline point of view or are germline unknown, we do want to do tissue testing looking for somatic RET mutations, because a majority of patients with non-inherited medullary thyroid cancer will harbor somatic RET mutations.
And I think another important aspect of this is involving the patients. So in the context of lung cancer, I think when a patient has a new diagnosis of lung cancer, they're really overwhelmed by the diagnosis, about the information that's associated with that, and there's a lot to process. And it's and in this context, I think there are some important things that we as physicians and nurse consultants or nurse practitioners can do as well. But I think there's also an important role that patient support groups and patient advocacy groups have in really providing information to patients, letting them know that they're not alone on this journey, that there are other people in very similar situations. In the context of lung cancer, they're fantastic patient groups, and they're different groups in different countries. In the US, in the context of RET-rearranged lung cancer, there's a group called the RET Renegades, which really has sort of focused or provided really strong advocacy for RET testing, for access to RET inhibitors, and I think that's really important. And I think there's a similar situation in the context of thyroid cancer.
There is definitely. So, I think that the role of patient education and involving patients in these really critical treatment decisions is so helpful. Patients are indeed often overwhelmed, and we are guilty of information overload all the time in clinic. So, circling back and reviewing the information with patients again for a second time or for a third time can really help patients understand what it is that we started talking about in our first visit, and they couldn't remember because everything else was swirling around for them. There are patient advocacy groups specific to thyroid cancer. The patient advocacy group called THYCA is one of the larger patient advocacy groups, and they do have a worldwide presence, and they also have RET groups within the overall THYCA organization. And, one of the things that I think we hope is that with better patient education, better patient advocacy, that we'll be seeing increasing rates of testing for these actionable alterations for patients with lung cancer, as well as for patients with thyroid cancer. We need to get a lot closer to 100% of patients being tested around the world, and the more the patients can partner with us in achieving those higher rates of testing, the faster we'll get there. And, I have to say that for most patients that are referred to me at this point in time, patients have never even heard of molecular testing or biomarker testing or NGS testing, and it's really only come up in their first meeting with me. So there's a lot of room for education out there.
Yeah, I completely agree. I think I think it's fantastic to have guidelines, but the real work is implementing in these guidelines. And I think I love the way you sort of phrased. I think you used the expression to really make sure that we don't leave any patient behind that has an actionable alterations. And we know that globally we don't get globally we do leave patients behind that 50% gap in testing, and and I think even bigger gaps in access are really something that we need to work together. And it's really by working together with our colleagues, with patients, that we'll be able to do this.
Yes, and one other advocacy group that I think we absolutely want to mention is the RET-positive group. This is another patient advocacy group that is specifically focused on patients with cancers that harbor activating RET alterations. They're doing fantastic work in this space as well.
Absolutely, and in the context of lung cancer is exactly the same.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/ANR860. This activity is supported by an educational grant from Lilly.